I'd like to welcome everyone to the Vasculitis Foundation webinar today. I'm Kathy Olewski, the host for the Vasculitis Foundation educational webinar series. I'm also a patient living with MPA vasculitis, and these webinars are part of the Vasculitis Foundation's commitment to patient education. Today's webinar is an overview of Mepolizumab with guest speaker Dr. Christian Pagnoux. After we finish this webinar today, there will be a recorded version on the Vasculitis Foundation's YouTube channel, and everyone who registered today will also receive an email with a link to it as soon as it becomes available. Let me begin by introducing our guest for today. Dr. Christian Pagnoux trained in internal medicine and clinical immunology in Paris, France. Between 2002 and 2010, he worked in a division who created the French Vasculitis Study Group, which is known as FVSG. And he served as vice president of FVSG. He moved to Toronto, Canada in 2010 and was appointed in the Division of Rheumatology at the Mount Sinai Hospital. He joined the steering committee of the North American Vasculitis Clinical Research Consortium, which we call VCRC, and founded CANVAS, which is the Canadian Network for Research in Vasculitis. So welcome, Dr. Pagnoux. I'm so happy to have you with us today.
Thank you, Kathy, for the kind introduction, and thank you to the Vasculitis Foundation for giving me the opportunity to speak again to all of you. So today it will be on Mepolizumab, and I guess that most of you know what is Mepolizumab already because you have some interest in that drug to be here. I'm sharing my slide now.
And Dr. Pagnoux, as you share that, I also need to ask you right at the beginning if you have any disclosures to share them with us.
Oh, perfect timing, because here is my disclosure slide.
Okay.
So I gave several talks on vasculitis over the past year, including with the support of GSK, that is the pharmaceutical company that markets Mepolizumab in North America and elsewhere in the world. So what we'll go over is what is Mepolizumab, brand name Nucala. There's no generic at this moment, but there probably will be in the next 10 years after the company loses their patent for EGPA. There will be some biosimilar, very likely. What it does, how is it given, and go over some clinical data, clinical evidence as to what it can do and how it was developed and eventually approved for the treatment of EGPA. I will not remind you at all about what is EGPA, Eosinophilic Granulomatosis with Polyangiitis. You can refer to some other presentation from the Vasculitis Foundation on EGPA, on other treatments for EGPA, to know better and more about the disease per se and about the pathogeny of the disease, because of course the treatment targets some specific molecules that are involved in the pathogeny of the disease. So let's dive into what is Mepolizumab. That's a drug that I've been using more and more for the past 10 years, and that's why I'm here today to speak and share about my experience with this drug in my patients with EGPA here in Toronto, in Canada. Nucala is a biologic medication. What is a biologic medication? That means it's a monoclonal antibody that is produced, that is synthesized in the factory from GSK, and that's what is called a humanized IgG for immunoglobulin type G1, kappa, that's the light chain, monoclonal antibody. So you can see that's the big molecule. It's not like aspirin that you see at the bottom right, which is just some small molecules. Here it's a 3D structure, it's a big thing. And I often explain to my patient that a biologic is like buying tomato versus aspirin is like buying sugar when you go to the grocery store. So there are batches of tomatoes that can be a little bit different from each other, whereas the sugar is always going to be the same. It's easier to produce. A biologic is something more complex, and there is some variation from one drug to another sometimes, and even from one batch to another sometimes, which may explain why sometimes people have some allergic reaction to one injection, but then the next time they won't get any allergic reaction, because it's a little bit different. So it's a monoclonal biologic antibody, and it's the first biologic that targeted interleukin-5, IL-5, that has been developed. IL-5 is another big molecule that's on the top right, as you can see here. And IL-5 is the main food, I would say, for the eosinophil. Eosinophil are type of allergic cells, immunological cells that are at the center of the pathogeny of EGPA. Eosinophil are cells that are important for allergies mechanism, for EGPA, of course. They're also important to fight against certain parasitic infections. We have to keep that in mind because here, by removing the food of the eosinophil, by blocking the IL-5, we want this eosinophil to starve and eventually disappear so they cannot cause the inflammation that we see in patients with EGPA. So IL-5 is a cytokine. We don't say it's food, we say it's a cytokine that promotes the maturation, the activation, and the migration of the eosinophils in the body, and more specifically into the tissue that are affected in patients with EGPA. So in the lungs, in the sinuses, but that can be in the heart, in the nerves. The main weapon of EGPA is this eosinophil that cause inflammation in the target organs. But they need their food, that is IL-5, and so mepolizumab is a monoclonal antibody, as we said, that will bind to the IL-5 and prevent the IL-5 to go to the eosinophil, and so there's no food. Eosinophil will starve, not be activated, and thereby no inflammation. Once the mepolizumab has bound the IL-5, it will be destroyed. It will go into the garbage of the blood system, and it will be gradually eliminated out of your body with the IL-5, with the mepolizumab, but it would not have triggered the inflammation cascade that causes EGPA. So mepolizumab is a big drug. You cannot take it orally because it's going to be destroyed right away. It's going to be digested. It's too big. So it has to be given in a different way. Initially, we'll go over that at some point. It was given as an IV infusion, but then it was found it can be given as a subcutaneous injection. So it's a subcutaneous injection that is, for the moment, to be received every 4 weeks, and that's called Nucala. And it's presented in 3 different ways. Either the auto-injector pen that you can see on the top, that's like patients who have diabetes, it's a simple injection, or some patients prefer with a needle. It's a needle that is already prepared, and it's also in some country in a bottle, and then you have to suck out with the needle the product and then do the subcutaneous injection. That's a medication that has to be stored in the fridge. That's just some practical information. Stored in the fridge. It cannot stay outside at more than 30 degrees. You know, there have been some heat waves recently. So if you're on mepolizumab, you have to remember it has to stay in the fridge. And if it's out of the fridge, it can stay out of the fridge for up to 7 days, but it should not be at more than 30 degrees. Otherwise, you can alter the compound, and it's not going to be dangerous, but it may not work as well. Another thing that's not that important to know, but it's still good to know, is you don't have to shake it. You know, when you have a needle and you prepare something, we often say, oh, I'm going to shake it before I do the injection. Don't do that with here. Same thing, it's not needed, and you may alter a little bit the efficacy of the drug by shaking it and destroying these big molecules. So take it gently, keep it in the fridge, and remember these practical things. So mepolizumab has been approved for the treatment of EGPA in December 2017 by the FDA. But for EGPA, that's the other picture, it's been approved at 300 milligram every week. And that's sometimes a question, is there a presentation, a formulation of 300 milligram? No. And that's why people who have EGPA and receive the EGPA dosing, there is no other option than to poke yourself 3 times every month at this different spot on the legs, but separated from at least 5 centimeters each poke. But you have to poke 3 times to get 3 times 100 milligram, total 300 milligram every 4 weeks for EGPA. So that drug has not been developed first for EGPA. I told you the target is eventually the eosinophils. But eosinophil is also involved, as I mentioned, in allergy. And you may have heard about something, and you know, for EGPA, there's often asthma. And there's a subset of asthma that's relatively common, that is the allergic asthma. but that's a synonym of eosinophilic asthma. And it's way more common than EGPA. So that's why mepolizumab was initially studied in patients with eosinophilic asthma. There was big randomized controlled trial that were completed in 2014. And so since 2015, it's been approved for the treatment of eosinophilic asthma. And because eosinophilic asthma is a hallmark of EGPA, naturally, it was subsequently investigated for EGPA and approved in 2017 for adult patients with EGPA. It's for adult patients. We still struggle sometimes to give it to kids with EGPA, but it was approved in 2017. So we already have more than 10 years of experience of this drug since it started to be developed and investigated. But it's true, it's not like corticosteroids where we have 50 years of experience. It's still a relatively new drug. And if you ask me, is it safe on the long term? We can discuss about safety for 10 years, 15 years of use. We still don't know if you take it for 50 years, how is it safe or efficient? Since mepolizumab has been approved for eosinophilic asthma and EGPA, it has also been approved in other new condition, hypereosinophilic syndrome, which is a mimicker of EGPA, but it's more a blood disorder. It's been approved for polyposis of the sinuses in patients who don't have EGPA. We know that a lot of patients with EGPA have sinus polyps, but there are some people who just have the polyps and don't have EGPA. For them also, it can help. And more recently, mepolizumab has been approved for another condition that is called COPD, chronic obstructive pulmonary disease. That's a disease that we see a lot in past smokers or even current smokers, and where the eosinophil may play a role, but it's a partial role. But surprisingly, mepolizumab also helped a lot of patients who don't have that problem with the eosinophil count. So mepolizumab has multiple facets and possible use, but we're focusing on EGPA. So mepolizumab decreases the eosinophil by shutting off the food of the eosinophil, the IL-5. And that's how it works, by reducing the inflammation. We said that the drug has to be taken every 4 weeks. Why? It's just because initially we studied how long does it take to work. And so the first time it was used for EGPA was in 2008, and that was published in 2010 here. And at the time it was given as an IV infusion. And so you give the IV infusion here, that's the first vertical black line, and you see that gradually the eosinophil count goes down. And I would say the lowest maximum efficacy, the lowest eosinophil count was achieved around month 3. And so that's why it takes a good 3 months to achieve the maximum efficacy of the drug, and it has to be given at repeat dosing until achieving this target. Since then, it's been used subcutaneously, and it was approved in 2017 based on that trial in EGPA that was published in the New England Journal of Medicine with Michael Wexler as the main author of that. And that was for people with EGPA diagnosed for at least 6 months, who had a refractory disease or relapsing disease and could not, in a nutshell, go below 7.5 milligram of prednisone. That was the target population for that trial. And that's something we have to keep in mind importantly, because everything that doesn't satisfy that definition for the moment is more experimental. So if you say, I was just diagnosed with EGPA, can I go on mepolizumab? Answer is yes. But in that study, you needed to have a diagnosis established for at least 6 months. If you tell me, I'm on prednisone 2 milligram because I cannot stop it because of my asthma, can I go on mepolizumab? Answer is yes. But you would not have been in the study because you were not at 7.5. You needed some prednisone, but only 2 milligram. And so is it working the same? Is it worth going on mepolizumab when you're stuck at 2 milligram? Many questions that we can go over. So in that study, mepolizumab was given subcutaneously every 4 weeks for 48 weeks. So that is to say 1 year duration. And it was compared to corticosteroids alone. and a placebo of mepolizumab. But in a nutshell, just corticosteroids. And we know that it was significantly better. 56% of the patients on mepolizumab had some flare, asthma, sinuses, or vasculitis flare, versus 82% of those who did not receive mepolizumab. It's not 100% efficacy, but it was way better than not having mepolizumab. And I would say more importantly for me is to be off corticosteroids. When you go on mepolizumab, can it help you to be off corticosteroids so that your asthma remains under control? And it happened in 18% of the patients with the mepolizumab versus only 3% of the patients who didn't receive the mepolizumab. Again, clearly better, but you may still tell me, well, it's a medication that achieves a fabulous success in 18% only of your patients. Why would it not be 81%? 81%, I would be super happy. It's 18%. That's true, which only emphasizes we still need to do better. We have clues with these new drugs to do better, to use less corticosteroids, but there's still room to do even better. And I can reassure you already, there are ongoing studies. We mentioned some of them. So since then, since that major study that was called the MIRRA trial that led to the approval of mepolizumab, there have been more studies conducted. There was one that compared mepolizumab versus benralizumab. Benralizumab is another medication to block the IL-5 pathway. It's a little bit different, and there's a video on mepolizumab that is available on the VF website. And here you see that by 1 year of mepolizumab, 300 milligram every 4 weeks, at 1 year, 27%. So here it's not 18%, it was 27% of the patients were off corticosteroids after 1 year of treatment with mepolizumab with a controlled disease, no flare of the asthma, no relapses, and so good efficiency, as opposed to less than 3% in the placebo group in the MIRRA trial. Again, that's the curve of the eosinophil count. In blue, that's you don't give mepolizumab, and you just give corticosteroids. In red is what happened when you give mepolizumab every 4 weeks. And you see that it goes down the first month, and at month 3, that's the optimum. So you need to have at least 3 months to assess the efficacy of this type of drug, but it starts to go down very early. As soon as the first injection, you see a massive drop, a massive reaction, but then it takes longer. It remains very stable thereafter. So if after 6 months you don't feel better, should you continue? I think that's when we discuss things, because it does not continue to get better. And in that study, the first one, the MIRRA trial, after 1 year, patients had to stop the injection. And if you stop the injection, you see that within 2 months, and in fact, if there is 1 month more, it would almost go back to the previous level. It's an excellent drug, but it seems to be only suspensive action. At least if you take it for 1 year. Maybe if you take it for 5 years, when you stop it, it may not go up that fast. But here we had the information that when you take it and when it works, if you stop it after 1 year, relatively quickly, you go back to what you were before. So that's why the treatment has to be longer than a year. We could say for life for the moment, but we don't like for life treatment. And we always hope that at some point, maybe we can stop gradually, or maybe we can switch to a different drug tomorrow that may do something different. So since the approval, more and more patients are being treated with IL-5 blockers. I would say in the cohorts, that's around 40%. Around 40% of the patients with EGPA are being treated with an IL-5 blockers nowadays. Not all of them, because some patients don't need that. They went well with steroids and something else. They're in remission of treatment. And because they don't satisfy the approval criteria, or maybe also you have to be aware that in some countries, it's not available. It's not approved everywhere. In Canada, it's approved at 100 milligram, but it's not approved at 300 milligram dosing. In France, it's approved at 300 milligram, but it's not covered. It's not reimbursed at 300 milligram. So what do? Where there are some patients who have very good private insurance plan, and we still can give them 300 milligram. And for those patients who don't have an insurance plan, well, we've been using the asthma dose. And the asthma dose is 100 milligram instead of 300 milligram every 4 weeks. And that's the figure that you see here. In red on the top is the efficacy of 100 milligram. Dark green is complete response. Light green is partial response, and gray is there was no success. And at the bottom is with the 300 milligram. So these are more studies for patients who have good drug plans. And you see the efficacy, full response, partial response, and no response. And you see that the green is not that bad. At 2 years, a good 63% of the patients had partial or complete response to mepolizumab. That's compared to 92% of the patients who receive 300 milligram. But 63 versus 92%, it's better. Better take that than nothing, I would say. And so we go on 100 milligram when we have no choice. And if it doesn't work, we try desperately to get access, a compassionate or something, 300 milligram. But it also tells us that if you take 300 milligram for, let's say, 5 years, maybe it's okay to go down to 100 milligram dose at some point to gradually transition to being off treatment. So it tells us that the full dose is great, but the lower dose still does something in many patients. What about the safety of this drug? As I said, first time it was used for EGPA was in 2008. That's almost 20 years now, almost, not yet, but almost. But it's not 50 years, so we have to keep monitoring things, and there are lots of registry. The most common side effect of mepolizumab, or what we as doctor consider as very benign. The number ones are headaches, joint pain, back pain, arthralgias, and sinus infection. But sinus infection can be due to the disease also. So it's tough sometimes to say, is it due to the drug or is it because your disease is not under control? Some patients have allergic reaction or limited rash, eczema, injection site reaction. It happens, not that often. And there has been some cases, I was lucky, it did not happen yet in any of my patients, with bigger reaction, which is called anaphylaxis or angioedema. And that's relatively quickly after the injection. And so that's why, at least the first time when we do injection, we keep the patient under monitoring for at least 15 to half an hour to make sure that there is no such immediate allergic reaction. And then if it doesn't happen, it's unlikely to happen, even though, as I told you, these are big molecules and there might be a batch to which you are allergic. So even if nothing has happened for 2 years, you will still have to keep that in mind because it may happen with a subsequent batch to then suddenly you have an allergy. That's the table from the MIRRA trial, how many patients have had adverse event. And I just want to emphasize 2 things here. When we go and play with the immune system, we always say immunosuppressant. MIRRA, mepolizumab, is not exactly an immunosuppressant because there was no signal of infection compared to the placebo. It's exactly the same. Corticosteroids is an immunosuppressant that triggers infection. It doesn't seem to be the case with mepolizumab. There was no more pneumonia than with just the corticosteroid. There was no signal in any type of infection. And I would say importantly and specifically, there has been so far no signal that there would be more parasitic infection. I told you that eosinophils are important to fight against hookworm, roundworms, trypanosomiasis, many parasites. Eosinophils are important. But here, there was no such things. It's a very nice signal. At the same time, we have to keep in mind that mepolizumab so far has been used in North America, in Europe, but not that much in the center of Africa or deep South America, where there might be way more parasites than we have in our countries. But so far, no signal, but your doctors know very well that we have to check for that. The other thing when we play with immune suppressant is cancers. We're always worried about will there be some lymphoma or weird cancer developing years later. And so far, there's absolutely no signal. Again, in the MIRRA trial with follow-up, There have been patients with cancer, 4 cancers, one in the placebo and 3 in the mepolizumab arm. These were renal cell cancer, colon cancer, and basal cell cancers that are very common cancer and with no clear causality with the medication. So far, no signal in terms of cancer. But I told you, it's 20 years of experience so far, and we keep an eye on that, of course. And that's why I don't like personally the idea of a lifelong treatment, because I don't know if I'm treating you with mepolizumab for 50 years or 30 years, will there be a signal? I don't know. I don't know. Time will tell. For the moment, I don't have that information. And that's what always drives me to think about, can we stop that drug one day? When you've been stable enough, long-term remission, no more steroids, perfectly well controlled, can we try and remove it at some point to not have a surprise 20, 30 years later? So who should get mepolizumab? Clearly, patients were in the MIRRA trial, 6 months, corticosteroid dependent or relapsing, but should it be given earlier? The European guidelines, the Canadian guidelines, for the moment we say that's clearly for patients who have refractory corticosteroids relapsing disease. The 2021 ACR Vasculitis Foundation guidelines has gone a little bit further by saying, you see here, in a patient with non-severe EGPA, mepolizumab and corticosteroids combination is the #1 option. Whereas in the other countries, it's corticosteroids alone, and then we see 60% of the patients will be at least corticosteroid dependent, and we will add mepolizumab then. Whereas the ACR guidelines suggest that everyone should be treated right away, not at 6 months, right away, with a combination of corticosteroids and mepolizumab. And corticosteroids alone should be considered in selected patients only. What it is, we can discuss about that. So you see, there's a trend to use mepolizumab earlier and earlier. What about patients with severe EGPA? Patients with severe EGPA, they need corticosteroids and a strong immunosuppressant, rituximab or cyclophosphamide. And mepolizumab will come after, because for the moment, we don't know if mepolizumab works so well for some specific manifestation. We know that there are some patients who have some genetic background that suggests that eosinophil is more implicated, whereas some have other genetic background which suggests that also the B cells and some other T cells are implicated, and so maybe some would benefit more than mepolizumab. Because there are many different targets in EGPA. As I said, B cell can be playing a role, so here we would use rituximab. In some patients, it's IgE that may play a role, so omalizumab. In some patients, IL-4, another food for the IL-6, may play a role, so there are new biologics. So there are plethora now, and that's a good thing to have so many options, possibility to maybe act. But for the moment, there are only 2 drugs up there that have been approved by the FDA. That's mepolizumab and benralizumab. All the others, rituximab, omalizumab, dupilumab, depemokimab, and so on, are either under investigation or not approved yet. The only 2 ones are benra and mepo to block the IL-5. Some of these drugs may work better for sinuses or asthma or vice versa. There have been papers showing mepolizumab works better for the sinuses, benra works better for the asthma. But then there have been papers showing the exact opposite. So I think time will tell us, but it's possible that in the future, we will refine further the way we treat you individually, depending on what is your specific, more concerning, more bothersome manifestation, so we can give you the more efficient treatment. And as I said, for the moment, we don't know exactly if mepolizumab works for bad peripheral neuropathy, for bad cardiac disease, and for bad kidney disease. Eosinophils play a role there, but there's so much inflammation that we don't know yet. Because I told you, in the MIRRA trial, people have to be at least 6 months from the diagnosis, and people with very bad cardiac disease were not enrolled in the study. So for the moment, we are just collecting cases and case series of people who have been treated with MEPO very early when they had bad kidney, bad nerve, bad cardiac, to see whether it works or not. And we don't have yet the information. So that's why today, if you have EGPA with cardiac disease, you will receive corticosteroid, cyclophosphamide, and maybe we will add mepolizumab, but mepolizumab does not replace the big immunosuppressant when there's a severe disease. What about the future? Will mepolizumab still be around in the next 10 years? In the next 10 years, probably. Beyond that, I don't know. I don't know why. Because we want to do better. I told you, it's a very good steroid-sparing agent nowadays, but we want to do better. So we're still looking for a more efficient drug. We're also looking for a drug that might work longer, so you don't have to poke yourself so often. And that's why there's an ongoing study. We will know the result of that study in a year and a half from now, because it's not yet finished, but soon it will be. That's to compare mepolizumab versus depemokimab. Depemokimab is the same thing as mepolizumab in a nutshell, but it works for 6 months. So instead of poking yourself every month, you would have to poke yourself every 6 months. And not only it's a longer action, but it inhibits the IL-5 even faster. You see the red curve, that's the time to inhibit IL-5 with mepolizumab, with depemo in red. It goes faster than with mepo. So a faster efficacy and a longer efficacy with a nice plateau that you see on the top that will last for 6 months or 5 months, we'll see, but less injection with something that might be a little bit more potent. So that's what I would call the version 2 of mepolizumab. So it's very likely that even if you stay on an anti-IL-5 monoclonal treatment, we might in the next few years switch you to something else than mepolizumab long term. Here are some just references for you, some of the article. So of course the paper, the cornerstone paper of the MIRRA trial that was in the New England Journal of Medicine from Michael Wexler and the group, and several articles of what is IL-5 that here I co-wrote with a colleague from Italy. You know that there are lots of international collaboration to treat EGPA. It's a rare condition. So to achieve the needed number to study a drug, we need a lot of patients, and it cannot happen in only one center, not even in only one country. It always has to be multi-center international trials to achieve all the development for these drugs. So that's what I wanted to share with you in terms of the basic information of mepolizumab. But I think now we have time for questions.
We do. Thank you so much for sharing that with us. And I have seen a few questions come in, so I'm going to go ahead and start with those. The first one is, has mepolizumab ever provoked 3 times or 4 times IgE increases in any of your patients?
No. So there is a monoclonal antibody that is called omalizumab to treat patients with hyper IgE syndrome. So it's a different target, of course. Omalizumab trigger that. Mepolizumab does not trigger a loop or rebound of IgE. No. There are drugs that can cause a rebound of something, but not mepolizumab.
Okay, thank you. And also a question from the same person, what percentage of EGPA patients taking, for instance, the 300 milligrams of mepolizumab are able to completely discontinue steroids? Do you know that?
So that's based on the case series. When it's reported, case series of something like 30, 40 patients. So it's a limited evidence. But in this case series, after 1 year or 2 years, around 45, 50% of the patients are able to stop the prednisone. All the patients are able to go down. Almost all the patients are able to go down on the steroid dose. But to stop it totally, it's around 50%.
Okay. And I had a question. You said that there was doses of 100 and 300 milligrams in France and Canada. Do you have a reference for what's been approved in the United States?
In
By
terms of
insurance. Yeah.
Yeah, I'm not sure. You would have to help me for that. But I think in US, I know it's way easier to get mepolizumab 300 milligram because we compare how many patients, the percentage. I told you 40% of the patients with EGPA nowadays are on mepolizumab or an IL-5 blocker. These are data in the US. In Canada, it's only 20%. So in the US, you have an easier access to mepolizumab. It was approved earlier than in many countries. And from what I know, it's approved at the dose of 300 milligram, whereas it's not in Canada.
Okay. Okay, well, thank you. I always wonder about how that affects people in different places.
Mm.
The next question is, oops, I just went past it. 1 second here. Back up. You touched on France, but are you looking at doing trials for this or is someone looking at doing for trials in the UK?
Yeah, totally. UK is part of most of this trial. They were part of the MIRRA trial. They're part of the MIRRA trial. So clearly, UK is a big player. Yeah, all the countries in Europe are big players. UK, Italy, France, Spain. You can name it. Poland, also a big recruiter for the MIRRA trial. China is also a big recruiter for the ongoing Ocean trial. So it's really worldwide. But as I mentioned, it's not in Morocco, Algeria, Tunisia, Kenya, even Brazil so far, not so much. Huh? Chile, Argentina, Venezuela are not part there. I don't know if there are as many EGPA over there. That's the first point. Huh? We don't have epidemiological study about EGPA in these countries. But the other countries, yeah, all of them are part of that.
Okay, thank you. And I almost forgot to mention this. One of your slides, you talked about storage and usage of Nucala or Mepolizumab, and you said 30 degrees Celsius. So I just wanted our US people to know that's 86
Yeah.
degrees
Yeah.
Fahrenheit. We're not always the greatest at converting. So that helps them understand the storage that you explained. Also, I wanted to ask you, one of your slides said something that it's approved for certain patients 12 years old and older. I was going to ask the pediatric question. So is it approved just in certain circumstances and is 12 the youngest?
So it's not approved for kids with EGPA. It's approved for asthma in kids at the dose of EGPA, at the dose of asthma, so 100 milligram. But the 300 milligram is not approved for kids. But it's
Okay.
been used. It's been used, and the pharmaceutical company has even developed some kind of a open label, one-arm study to try, and it works the same. So the question is really the coverage and the access there. I don't know how it is in the United States, but in Canada, the coverage for kids is even if it's not officially approved, it's usually we can get access to almost everything we want in kids. But then comes the problem when they transition to 18 years old and they transition to me, and I have to tell them, hey, all the drugs that you got for free, compassionate when you were at the hospital as a kid, it's over now. You're an adult. So how are we going to make it?
Right. Understand. There is one other question in here, but it does go into a little bit about the individual's personal medical situation. And I did say at the beginning that we would not ask Dr. Pagnoux to comment on those questions. So I'm sure if you want to submit that question, maybe we can get some follow-up from the Vasculitis Foundation for you. Any other questions that anybody has? I'm not seeing any other questions that have come through. Well, Dr. Pagnoux, thank you so much for doing all of this for us. We greatly appreciate your time. I did see some comments and some nodding heads from a bunch of people that they really appreciate the time that you gave us today, as always. And I did want to share, just see if I can share my screen successfully today. There we go. That should be showing. Yes. Except there's a lot of things all over it. So let me close those out. We did want to remind our viewers today and the viewers that watch this later on that we have a great website through the Vasculitis Foundation. It's really wonderful for those of us that are patients. You can find all kinds of helpful information about vasculitis. For instance, under the education tab, you can learn about specific forms of vasculitis. And even after you've read about it, you can then go to the resource tab and under order print, you can find a short document that you can print out for family and friends, or that you can even take to your primary care doctor's office. I always mention that I took it to my dentist's office recently because he'd been asking about my form of vasculitis. On the VF website, you'll also find a video library with all of the recorded webinars. On the homepage, you can find out more about the patient support groups. Those are just, an unbelievable resource. And then there are upcoming events like webinars, as well as all of the fabulous Vasculitis Foundation conferences that we get to go to. And I'd also like to let our viewers know that when you leave this webinar today, a survey will pop up. In this survey, we would like to know if you thought today's webinar met your needs. This is part of a series, so we want to make sure we're meeting the needs of everyone and making the series successful. So when it pops up as you're about to log out or just after you log out, please click on the word continue to take the survey. Each person registered for today's webinar will also receive a follow-up email with a link to the recorded version of this so that you can share it with friends if you'd like to do that. And of course, I'd like to say thank you to Dr. Christian Pagnoux for all of the time and effort that he put into doing this presentation for us. We know you have other things that are important as well. And thanks to the Vasculitis Foundation for supporting these educational webinars for the patients. And that's it. Thank you so much, everyone.
Thank you. Bye.